Well, thank you so much. It's great to be part of the meeting next time live. I want to talk to you a little bit about augmented reality, and this is based on some personal experience, but also based on reviewing the literature. I want to thank my fellows for helping me put that together. These are my disclosures. And I want to remind everyone, and we talked about navigation earlier, and I know there was a really nice presentation in the lab earlier with the robot. All these stereotactic navigation technologies are really somewhat connected, right? You've got the imaging technology on the left side, so you've got your intraoperative or preoperative imaging, and there's 2D and 3D. And then you have your navigation technology, 2D navigation, freehand navigation, 3D navigation, robotics, and then the software that kind of communicates between the imaging and the navigation. And I think it is important that these are all connected, at least in the stereotactic optical navigation world, freehand navigation, robotics, AR, VR. I think as surgeons, we should really keep in mind that these are all connected in order to not to have one fight the other, but really keep them all together or use them appropriately as indicated for our surgical procedures. And I think if you do that properly, and sometimes you mix and match different technologies, I think you can really take advantage of this exciting technology. And there's so much research that is being done, and obviously clinically it's being used so frequently. I just want to show you that, in my opinion, if you look at the spectrum of spine surgery from least complex to most complex on the right side, I think advanced visualization technologies, and that includes AR, but also freehand navigation, which is kind of like the bread and butter navigation that many of us now use. But I think the point is that 10, 15 years ago, it was unclear whether navigation would really have an impact on spine surgery. But most of us probably agree now that there is a role across the whole spectrum of spine surgery for some type of navigation. And then there are other enabling technologies that are somewhat limited, but I think the interesting thing is that these navigation technologies really can help us with any type of procedure. And not only procedures, also preoperative planning, teaching, training, and so forth. Now, I want to focus in on augmented reality, and you all know what that is, of course. It's basically superimposing computer-generated images over your view of the real world. And that may be the microscope, that may be your goggles, that may be the endoscope or an exoscope. But you basically superimpose computer-generated images. And what are those images? Those could be the pathology, a tumor, but it could also be regular anatomy that you need in order to proceed over the course of an operation. Augmented reality encompasses so much more than just putting in pedicle screws or really helping you during a particular case. There's a role of augmented reality in preoperative planning, of course. Intraoperative navigation is what we're mainly talking about today. Education, training, patient engagement, and postoperative review. We have a group in the sports medicine, the physiatry group, they use goggles now for pain control, postoperative pain control in patients with augmented reality, and they've done really great work on that. And that could obviously benefit our patients as well. So you can see there's a wide spectrum of possible indications for AR. I'm going to focus primarily on intraoperative navigation. And here we have, of course, the head-mounted display on the left side that most of you are familiar with. I've done really more work with the traditional microscope and then superimposing AR-generated images or computer-generated images into the view that I have under the microscope. Ibrahim Hussein, one of my partners, has done some work with a company called OnPoint. They have a very, very low profile headset that you can actually flip up and then still use the microscope. And we started doing this work maybe about 10 years ago. So I used the software that was made by Brainlab for brain tumor surgery, and I applied that to spinal tumors. And that was kind of the initial attempt to see if augmented reality really has a value in spine surgery. We do a lot of minimally invasive tubular tumor resection in the spine. So I would look at the MRI scan, and others obviously have done that now also, but we would look at the MRI scan, mark the tumor, and then transfer that to the intraoperative low-dose CT scan and navigate on these patients with augmented reality under the microscope. So this is a lumbar schwannoma here that we're resecting, or ependymoma that we're resecting through a tubular retractor in the lumbar spine. And this just shows you that the navigation here, or the augmented reality, is really spot on. And it helps you with planning of the incision. It helps you with bone drilling, so you kind of know how much bone you have to remove. It kind of takes a lot of what Victor said, the stress out of an operation. And if you look at this has been also done by other authors. There's a group from China that used augmented reality to plan the resection of intraspinal tumors, and they found that the localization time was significantly reduced with augmented reality compared to X-ray, where you have to bring in the X-ray and then wait for the X-ray tech and everything, and then put in a spinal needle and so forth. So there was a reduced localization time, and the incision was smaller because they could really kind of tailor the incision to the extent of the tumor. This group from Turkey used a different type of augmented reality to help with the intraoperative localization and resection of spinal tumors. So there are many different technologies out there, and I still use this pretty much routinely for my intradural tumors. Now, the other thing that most of us are obviously interested in is placement of instrumentation, especially pedicle screws. And this is, again, this is one of those low-hanging fruits really for spine surgery, because it is important. Of course, it's frequently done. It has to be very, very precise and accurate. This was one of the earlier studies that was done by Mike Wang and published with AR, placement in cadavers. But this has been done with various iterations of augmented reality technology with different types of headsets now. And this is probably one of the larger studies by Timothy Whitham. It's a meta-analysis looking at the accuracy of placement of pedicle screw placement with augmented reality technologies. And overall, it was very, very accurate. And they suggested that one should study more cost effectiveness, operative time, radiation exposure, and so forth. But we're pretty much there, knowing that augmented reality for pedicle screw placement is very, very safe and very effective. Now, this is a chapter that we wrote a few years ago comparing TLIF surgery. And Victor talked a lot about TLIF surgery. And it is always fascinating to see how different surgeons really do the same operation slightly in a different way. And for me, it's always an opportunity to learn. And we put in this book chapter, we compared 4 surgeons from Singapore: Kevin Foley from the US, Nestor from Latin America, and Barbagallo from Italy. And we asked them to list step by step, how do you do an MIS TLIF? And it was very interesting to see that there were slight variations, of course. We were interested in this also for teaching and training purposes as part of the AO expert group that Christoph is also part of. So we put together a curriculum for MIS TLIF surgery, a step-by-step curriculum that tried to kind of homogenize each and every step for MIS TLIF surgery, thinking that it would be important to do this for teaching and training. And TLIF is a great example because it has all these bony landmarks, and it has all these challenges, especially for younger surgeons, where you have to combine minimally invasive surgery, microsurgery, orientation, navigation. So we thought it would be really interesting to see how augmented reality can help us do TLIF surgery. We published this a number of years ago. I think these were 20 TLIF cases that we did with augmented reality. So on the right side, we used the TLIF algorithm, or like the curriculum, step-by-step technique that we described for the AO. But then we incorporated augmented reality for the facetectomy and for the cage placement, not for the screw placement. So we had a preoperative CT scan. We identified the landmarks for the TLIF procedure, and then fused that with a low-dose intraoperative CT scan and used augmented reality to find the lamina, the pars, the facet joint, the disc space, the trajectory of the disc space, and so forth. So essentially to facilitate the workflow of this operation. I apologize. So the screws we put in with regular freehand navigation, but then for the rest of the operation, we used the landmarks identified intraoperatively or preoperatively and visualized with augmented reality through the microscope. So the landmarks, there's 7 landmarks for MIS TLIF surgery based on our MIS curriculum. There's number 1 is the inframedial edge of the ipsilateral lamina. That's really, once you have your exposure, that's when you start drilling, or you cut from 1 to 2 then to remove the inferior articulating process, or some surgeons use the osteotome. Then you go, I want to know where the facet joint is. Then you go to the ipsilateral caudal pedicle and find the exiting nerve root and the traversing nerve root. So basically, you go from 1 to 2, 2 to 3. Then you find the pedicle below. You decompress everything, the exiting nerve root. Sometimes you want to feel the cranial pedicle, number 5. Then you go to the discectomy. And eventually, if you do over-the-top decompression, you want to also see the contralateral pedicle. And this is kind of the intraoperative or preoperative marking of the anatomy. We used, again, the brain tumor software that BrainLab has. That's not ideal. We're working with BrainLab on optimizing this. And eventually, you'll be able to identify all these landmarks, of course, with AI. So you don't have to mark anything yourself. The computer kind of marks it for you. So then intraoperatively, we bring in the microscope for the facetectomy, and this is just some intraoperative video footage showing some of this augmented reality anatomy that we're using. But I want to show you this video here, because this kind of really summarizes the procedure. So again, we're looking at the lumbar spine from the left side. We're looking at L4 and L5. We're doing a TLIF from the left side. I'm marking the skin incision. And just by looking through the microscope, you can already see the outline of the pedicle here. The blue straight line is the perpendicular line is the disc space. The light blue line, there is the facet joint. The yellow spot, the yellow dot is the inferior edge of the lamina, where you want to dock your dilator, but also where you want to start drilling. Now you drill from yellow to green. Green is the pars. So and then you remove the inferior articulating process. This is a real spine model that we're using here to do this operation. Then you find the ipsilateral caudal pedicle, which is on the green circle on the right side. You remove the SAP. You make that cut right above that pedicle. That exposes, the modified Cambin's triangle here, the medial edge of the dura in the upper part. And now we either do the discectomy or we go over the top if you want to do an over-the-top decompression. I think in this case, we went over the top. Actually, no, we did the discectomy. So the blue line, and if you look on the lower part of the image, you can see that blue line going down. That shows you the trajectory of your microscope. So you can also, by incorporating the information that you have at the lower part of the screen here, you can actually determine the trajectory of the disc space and then the cage that you put in. This is going over the top, looking at the contralateral pedicle there, confirming that you have a really nice over-the-top decompression. And so it goes on and on. So that's kind of how we used in those patients the augmented reality to facilitate the workflow. That's the contralateral traversing nerve root now that we've got completely decompressed. So again, this is just looking with a lower magnification. It just really gives you the safety and the peace of mind and the Zen feeling, that what Victor called the Zen feeling of having the anatomy there and knowing exactly where you are. So there are different types of navigation then, right? There's navigation where you want to be 150% precise. When you put in your pedicle screws, you don't want to be off by a millimeter. So there's accuracy and precision. And I think that's where robotic surgery and freehand navigation come in. But augmented reality is really more about orientation. It's about workflow, and it's about quality of less mental demand during the operation. And as Victor said, if you do 300 cases, then it really makes the difference for the surgeon. This is intraoperative imaging in a live case using augmented reality for an MIS TLIF procedure. And then we did a study with Claudius Tomé from Innsbruck. We did a study with 6 surgeons in Austria and 6 surgeons in New York, and we had them do MIS TLIF surgery 3 times in a row with and without augmented reality, with exactly the augmented reality that I just showed you. And then we had them assess the mental demand associated with this. And this is based on the NASA task load index, which is a measure of perceived workload. This is increasingly important, especially nowadays with millennials being interested in their workload, but also for us surgeons, I think. Again, if you do hundreds of these cases, it's much better if you can reduce your mental workload. And as you would expect, looking at how mentally demanding was the work, how physically demanding, the level of performance, the frustration level, and all that was significantly less with augmented reality. And overall, there was a great preference in augmented reality over doing this without augmented reality. So less mental demand, less cognitive load, better performance. Interestingly, just published recently in endoscopy, Christoph may know this study where they actually did the same thing using augmented reality in endoscopy surgery, and they found significant reduction in mental workload and workload in general with augmented reality. And in endoscopy, they wear these goggles. You don't see anything other than what you have in front of you in this screen. And for endoscopic surgeons who are always looking at screens all over, this is probably especially a benefit. So I just want to summarize. So augmented reality, I think there's a real interest, or should be much greater interest, not only for intraoperative navigation, certainly not only for pedicle screw placement, but really to use augmented reality to facilitate the workflow. There's a huge potential here. Of course, education, training, preoperative planning, patient engagement, postoperative review, all these things, the combination of VR and AR certainly is appropriate. Keep in mind, augmented reality, in my opinion, is really more about workflow and speed. Freehand navigation and robotic surgery is more about accuracy and precision. But I think we should bring those together and take advantage of what this technology has to offer. So I want to thank Rod and Paul and Christoph and everybody for having me there. And thanks for your attention.
Roger, great presentation. I always enjoy your talks. I always feel like I learn at least something new. And you're definitely a pioneer in AR. I think I've seen your talks over the years, and the brain tumor stuff you were starting off at the very beginning was very novel. And I agree with all your points. I think, particularly with endoscopy, to be honest with you, like I'm a novice endoscopist. Christoph here is an expert, and so is Osama here. A lot of faculty are, but I've been playing around with it, and I swear it's like when I start, the first view you get with the camera, I have no idea where I am, and 20 minutes later, I still have no idea where I am, and I would argue 60 minutes later, I'm still kind of figuring out where the heck I am. It's just you don't have any landmarks. You got this small camera picture, and this is where I think AR would be fantastic, right? It's all orientation, if you ask me, and loss of orientation or trajectory leads to complications. You're just not sure where you are, so you start picking at tissues sometimes, and you may grab something inadvertently. And so your small snippet on endoscopy and the benefits, I think really resonates with me. Fantastic presentation.
Thank you.
Yeah, Roger, I want to echo that. I think you're really a thought leader in that area, and I think one question I had for you that is really I wanted to ask you many times. Number one, I obtained the information. They don't have a curved one, of the oscillating drill, so I got that for you. But they have and Vic is out there in the lab right now, and he's going to show it to you in just a second. So. I had it here right now. So the oscillating drill that they have is not curved, but has a really nice line of sight. So I think, because you're using some of the smallest tubes in New York City, so I think it would fit in there. I think it looks actually really nice, so you should try it. My little point here that I wanted to ask you is, how have you seen that augmented virtual reality helps you to, kind of like teach the planning for a procedure? As we all know, MIS and endoscopic surgeries, if you don't get the incision right, the trajectory is right, you're going to suffer for the next couple hours because of it. And so for that reason, for us, it's very difficult to teach and give that part of the procedure to our trainees. How have you seen that you're now able to kind of like delegate more of the planning and still have the case done exactly to your liking? Do you see it, has that changed a lot in your practice?
You mean for myself or when I do this with a resident or fellow?
When the training of we're all present, right, and watch them, but how can you, because I mean, that's hard, some of those things are hard to teach. Do you feel that this is a really good teaching tool, actually, right, already before surgery, before you start to make the decision, really for planning already, kind of like include them in that mental process?
Well, absolutely, and I think that that's exactly one of the reasons why we should look at this more. And I also, if you use it properly, people are always worried about navigation, that you forget about anatomy. I think actually the opposite is true, because we're still looking at anatomy a lot, even more now with navigation than before. And especially what you mentioned, when you plan a case preoperatively or intraoperatively, you bring in the navigation system, you look at different trajectories, you look at different landmarks before you even make incision. It teaches you a lot about anatomy, right? So I think that the navigation does not preclude a good understanding of the anatomy. I think the opposite is true, but it's a little bit, the process is a little bit different. And maybe the tactile feedback is a little bit missing, But that comes over time once you bring in instruments and then you feel that I get the tactile feedback, of course. In my daily practice now, I don't use a lot of augmented reality simply because we don't have the right software. What I showed you was all based on BrainLab, the brain tumor software, and I'm trying to convince them to work with us to work on better software to create those landmarks easily for surgeons. It's very hard to convince companies to really see this as a benefit. They're only interested in screw placement. So we're working on that. For me, this is a no-brainer. And also what Paul mentioned, of course, I have the same sentiment when I look at endoscopy videos, And I saw AR being used actually by BrainLab in a lab about 3 or 4 years ago in Munich. And it was so wonderful, but I don't know what happened to it. I don't know, maybe Christoph, maybe but it made so much sense, and they stopped working on that, or maybe the.
Yeah, no insight. I've heard about that too, but I've never seen it. So,
I mean, it's a totally low-hanging fruit in my opinion, and it would actually, I think, be a huge thing for endoscopy if you can integrate that for new surgeons or get people on board.
yeah, no, I think the smaller the operative field, the more important the enabling technologies and sort of give you that, and even within an MIS surgery or an endoscopic field, you can get lost. So I think you're totally right. The smaller the operative field, the more, like outside information you need. So, yeah.
We have my favorite two endoscopic surgeons there, Osama and Christoph.
Yeah,
Osama, we've been waiting for you. Where are you?
yeah, well, you have to wait until the latter part of the session. They're going to give you their expertise. So I think, thank you.
Thank you, Roger.